The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody. That was Gloria Estefan. In my opinion, she is one of the most fabulous female vocalists ever, and she might have been popular before you were even born. A lot of the music today will be from Gloria Estefan. And I actually went to a couple of her concerts, and I've been to a lot of concerts in my long life. But I can remember in both of the Gloria Estefan concerts we went to, she had people dancing in the aisles like everybody. She's great. Well, this is Dr. Minarsik. We're still in the Chicago area, Zion, and it's still cold. Not as cold as it was earlier this week, but I'm still wearing my nice warm fire sweatshirt, which I actually went out in yesterday without a big coat because that's how warm it is. It's tropical here. It was actually got into the 30s yesterday. And today we are going to have part 2 of our part 4 series on endocrine disorders or endocrine diseases. Now, 2 days ago, 48 hours ago, we did part 1, which is entirely devoted to pituitary and to thyroid. Today, we're going to do all of the rest of the generally regarded endocrine glands. And if you kind of make a list, you're going to know that that's probably going to be the parathyroid, the adrenal cortex, and the adrenal medulla. And even though they're all in the same gland, they have such unbelievably different functions that you might as well be separate. Just like the thyroid and parathyroid. And then we're going to talk about this very mysterious thing, just say a few words at the end about the so-called pineal gland, which is a big mystery even today, even though melatonin is $1 billion market. And I actually took some of it myself. Okay, what else do we want to say? In the broader spectrum, we will have 2 more webinars after this in the endocrine series. And we will spend the entire 3rd webinar 5 days from now on February 15th. Remember, we're going to be skipping Valentine's Day, so that's why I put the Valentine up there today. And then on the very last 4th webinar, a week from today, I believe the 17th, we'll be doing a review in the histopathology lab. Now, we also may be doing what I called a USMLE review. I did one USMLE review this year. I don't know how it went off, but I do know if many or the majority of you are basically attending this course because you plan on taking that test. And if you show some feedback and support, you say, yeah, we want to do USMLE, I'll probably do that in the very last webinar with the virtual microscopy histopathology lab of the endocrine system. So here we are, February 10th, ENDO2. This is also our 38th webinar of the year. Now take a look at this. What do you see? Well, what you see is not many numbers. If you remember, usually when we do a webinar, we cover from anywhere from 50 to 80 PowerPoints, and sometimes those are pretty long. And something that's like over 60 is probably going to take the full 2 hours. Well, guess what, folks? This is only 35. Today will be, the way it turned out, I guarantee you a short webinar. Now, I know I've always promised you short webinars, and sometimes I didn't keep my promise, but it's very, very unlikely that we will go much more than an hour today. I hope that makes you happy. I know it makes me happy because that's just the way it turned out. Okay, well, I guess we could get going now. I don't have anything else to say except what I said in the first endocrine webinar. It's my favorite topic, okay? And I know you've heard that line before. So let's pop it up here. And we did the pituitary. We did the thyroid. And maybe you might think, if you took histology, which I hope you did, that this is a parathyroid gland. Whereas the thyroid gland, we said weighs what, 15 to 30 grams or something like this? This is tiny. This is about the size and the weight of 2 pieces of rice. The average parathyroid gland's 35 to 50 milligrams. You know, that's 1/20th of a gram. That's 1/20th the size of a pea. That's 1/20th the size of the pituitary gland. And furthermore, look, about half of it is fat. And that's why it's kind of yellow. And sometimes when you look at them on the posterior aspect of the thyroid, they could be very hard to find, but generally they're softer and more yellow than the thyroid itself. But they're so small, the surgeons very often do not know for sure if that's the parathyroid. So sometimes they call us into the operating room and they ask us maybe to do a little slice of one to make sure. Because when they do thyroid surgery, for whatever reason, usually cancer, or maybe something else, they always want to preserve the parathyroids. Why is that? I'll tell you why. It's because you could live without your thyroid gland, but you can't live without your parathyroid. So sometimes I take these four little critters, which are never ever where you expect them to be in the textbook, you know, symmetrically, superior, inferior, right and left. They're all over the place. And they might transplant them somewhere else that's safety, even in things like arms and stuff like that. So look, it's half fat and half parathyroid gland cells. Now, most of these cells that are kind of purple, like these and maybe these, but I'm not sure, but these and these are the chief cells. And why are they the chief cells? Because they are the principal chief cell. It's about 90% of all the cells. Okay, it's also the cells that make the parathyroid hormone. Now, sometimes if you look carefully, you'll see clusters of red cells, like over here and a few over here, and a kind of a bigger area here. These are oxyphil cells, and we talked about oxyphil cells when we were talking about thyroid. And basically, the oxyphil cells do not secrete parathyroid hormone. So the principal cells, the chief cells do, but the oxyphils don't. So what do the oxyphils do? I don't know. Maybe they kind of give rise, or maybe they're just there. I don't think anybody's ever really known for sure. But they're red and granular because, like all of the oxyphilic cells, wherever you find them in the body, they're just loaded with mitochondria. Okay, so much for general comments about the parathyroid gland. Now, in the function of the gland, I think it's one of the easiest and most logical physiologies that I can ever understand, okay? Here's a histology of, once again, a closer up of the parathyroid gland. You can see almost all of these cells are chief cells. Here's a couple of little clusters of oxyphil cells. So these are the cells making the parathyroid hormone. Half of it is fat. And what causes the parathyroid gland to secrete parathyroid hormone? Well, you could probably do a lot of little arrows and physiologic maps and stuff, but after all is said and done, the principal driving force for the release of parathyroid hormone is a low serum calcium, or hypocalcemia. Now, I don't normally measure or memorize values of normals, except in rare cases, but here's something that's kind of interesting. The normal range of a human serum calcium is very narrow. It's only from 9 to about 10.5 milligrams per DL. If it falls much below 9, those parathyroid gland chief cells know that, so they start to secrete parathyroid hormone. Now, what does parathyroid hormone do? Well, it does the opposite of what the parafollicular cells making calcitonin does. Parathyroid hormone tells the macrophages of the bone, okay, to chew up some of that material, that crystalline hydroxyapatite calcium, and take it away from the bone and put it into the blood, because 99 point something 9% of the calcium in your body is stored in bone. So when the calcium runs low, the parathyroid hormone chief cells tell the osteoclasts, which are multinucleated histiocytes in that line, to start chewing up the bone and taking some of that calcium out of the bone and put it back into serum because it's low in the serum. Now, if you want me to reinforce what I just said, I will also say that it does exactly the opposite of what calcitonin does. In fact, that's probably the biggest obvious relationship between the thyroid and parathyroid, is that these interfollicular cells or parafollicular cells, see, here's a follicle, here's a follicle, here's a follicle, and then sometimes you get these lighter little cells between or para or interfollicular, which are called parafollicular cells. Sometimes I've heard them referred to as light cells or C cells, but these are the guys that make calcitonin or thyrocalcitonin, okay? And thyrocalcitonin does the opposite of parathyroid hormone. So as where parathyroid hormone takes calcium from the bone and puts it into the blood, calcitonin takes it from the blood and puts it into the bone. Only now, rather than telling the osteoclast to put it back in, it tells the osteoblasts to lay down more bone, okay? And eventually that becomes calcified, okay? So you could think of these two as being totally complementary to each other. PTH takes the calcium out of the bone when it's low in the blood, puts it into the blood. Calcitonin takes it out of the blood, tells the osteoclast to lay down more osteoid and then crystalline osteoid, which is called bone, and put it back into the bone. Okay, so much for the anatomy and physiology. The parathyroid disorders, you notice that in our usual description of diseases, we usually say degenerative, inflammatory, neoplastic, but the parathyroid disorders are basically defined more functionally in terms of whether they are hyper-functioning or hypo-functioning, or not hypo-functioning, but the targets to which they go, the end organs, are more resistant to it. So it is like a hypofunction. And I hope these are all logical to you. In primary hyperthyroidism, primary hyperfunction and enlargement and more chief cells is usually due to parathyroid adenomas. Okay, so the larger the adenoma, the more the chief cells, the more calcium is going to be put into the blood, the higher your calcium is going to be. So hyperparathyroidism goes hand in hand with hypercalcemia as well. Now, do you remember when we talked about renal failure? We said that as the potassium may rise in renal failure, the calcium actually gets low, okay? Due to a good specific physiologic reason. Well, what does low calcium mean? Well, it's a stimulus for telling the parathyroid to get going and put some more of that calcium into the blood. So, a primary hyperthyroidism is adenomas. Technically, it could be carcinomas, but I've never seen one, and it's rare. And every time I say that, I Google it after the lecture, and I go, oh my God, I say, it never occurred, but you could probably find some rare case reports. So, in secondary hyperparathyroidism, the calcium is also high because the low blood calcium triggered off an excessive amount of parathyroid hormone to make up for it. So the parathyroid hormone doesn't just replace the low calcium, but it usually makes it high, okay? Now, what about hypothyroidism? Well, the thyroid surgeon's greatest fear is that he's going to take him out accidentally when he does the thyroidectomy. So surgical is always on the list of causes of hypothyroidism. Or, you could be born as a congenital, in fact, as a specific genetic disease. You might remember we talked about the 22q11 deletion syndrome, where the long arm of chromosome 22, the 11 position, is deleted, and therefore one of the things is that there's inadequate parathyroid function before birth even. So the 22q11, or also called velocardiofacial, these are usually kids, okay, and they have their own poster child and everything. Or there's even a relatively rare familial, separate from the congenital syndrome, for hypoparathyroid function. And of course, we always have to throw in idiopathic. So whenever you have a list of something and you've exhausted all the possible things you could think of that are related to it or cause it, you always have to throw in idiopathic, because sometimes you just don't know them all, right? Okay. Now, when we talk about diabetes in the next lecture, we're going to say most of the adult onset diabetes, okay, is not necessarily due to decreased insulin, but increased organ resistance. And that's what you would call a pseudo hypoparathyroidism. Sheath cells are making enough parathyroid hormone, but their end target, okay, the bone the bone chewing osteoclasts have a higher demand for it. So what they're getting is really not enough. Okay, so that would be pseudo hypoparathyroidism. So hyper, hypo, pseudo hypo. And pseudo hypo does not involve an actual low serum parathyroid hormone level. Now, what about hyperparathyroidism, okay, itself? Well, what happens if your parathyroid hormone is chewing up too much bone and taking out too much hydroxyapatite, too much calcium, okay? Well, that bone is more susceptible to fracture. The bone is more susceptible to pain. Your bones are being chewed up, literally speaking. That increased serum calcium, the hypercalcemia of hyperparathyroidism, you could almost use the terms interchangeably, okay, can cause stones in the kidney. It could cause stones in the gallbladder. And when we get to the chapter on gallbladder, you're going to see that most stones of the gallbladder are not calcium stones. It's only a relatively small percent, maybe 5-10%. I don't know. It's not much. But most of the stones of the gallbladder are either bilirubin or cholesterol. But if you have gallstones in a patient with hyperparathyroidism, you could probably bet that those will probably be calcium gallstones. Remember we said calcium stones were common in the kidney but rare in the gallbladder? Well, a gallbladder of a patient with hyperparathyroidism, they're common. They can also get ulcers in their GI tract. They can also have hypomotility of their GI tract, become constipated. Clinically, they can become depressed, lethargic, okay? And if you look at their EKG, if you're a big EKG person, and I can't explain this, but this is a common knowledge kind of a thing. If you take your QT interval, which is from the beginning of the first deflection of the Q wave to the end of the T wave, that interval can be measured in terms of time. In hyperparathyroidism, that time is shorter than it should be. Okay? And even though it's shorter than it should be, the T portion of the QRST segment, okay, could actually be widened. So it might be a little bit less sharp than what you see here. This is a totally normal, EKG. Going along with the depression and the lethargy are general also things like weakness and fatigue. Now, wouldn't you think that with hyperparathyroidism and increased serum calcium, probably the most obvious clinical effect will be calcifications. And we talked about the concept of metastatic calcification. We did not say that it's due to metastatic disease chewing up the bones. We said it's due to hypercalcemia. Now, technically speaking, in hyperparathyroidism, you do have hypercalcemia. And you can also technically have hypercalcemia if your bones are diffusely being chewed up by metastases also. But the metastatic calcification has nothing to do with tumors. It's due to the fact that an extremely high serum calcium will be depositing calcium everywhere, not just in the gallbladder, not just in the kidney, okay, but anywhere, in soft tissues even. Also the valves of the heart. So, there's a lot of reason for having calcified heart valves. But if the patient has hyperparathyroidism, the connection is easy to see. The high serum calcium is being deposited in the valves, as well as probably a dozen other places as well. Let's look at the opposite side of the coin. So a lot of the things that we saw with hyperparathyroidism are opposite in hypo. For example, remember we had a short QT interval? Well, up here you have a widened one. And that's strictly because of the effect of calcium, during the QRX complex, okay? It has nothing to do with the hormone itself. Why would you have defective carious teeth? Well, it's because the calcium in your enamel, calcium in your teeth are being replaced and chewed up by the osteoblasts. So that's one reason for have soft, defective, carious, or cavity-filled teeth. Now, if you have a low serum calcium now, you also can have not only neuromuscular irritability, okay, or twitching, we could say. Last year, I think I had a sign of an actual movie showing somebody having a Schwastek sign where if you tap on a portion of the jaw, the muscle twitches. And that twitching can actually look similar to the same quivering or tics that you can get, or irritability that you see with Parkinson's-like disease also. Now, it's not surprising. Somebody with a really low calcium is going to have a mental status change, just like we looked at some of these mental status changes like depression, fatigue, lethargy with hyper. So that's kind of a non-specific thing. It's also something that's common in just about any serious disease, okay? So much for the hypoparathyroid, the histology, the physiology, and let's move on to the next endocrine gland. It's going to be the adrenal gland. Okay, maybe, maybe you might say it's the most important gland. Some people might say that, who knows. But the adrenal cortex is separate in function and histology from the adrenal medulla. Okay, the adrenal cortex is like a real gland. It has glandular type cells. It makes hormones, mostly steroid hormones of different physiologic functions. Whereas the adrenal medulla is more like a sympathetic ganglia. Okay, so let's deal with just entirely the adrenal cortex first. If you remember from histology, there's 3 layers to the adrenal cortex. The most superficial one, the cells are arranged like little balls or glomeruli, like you see in the kidney. That's called the glomerulosa. And that part of the adrenal cortex is really greatly involved with salt metabolism, okay? If you remember, aldosterone retains salt and it gets rid of potassium. So aldosterone is the main hormone of the zona glomerulosa. By far, the thickest portion of the adrenal cortex, the cells are lined up like little fronds, from a palm tree or fascicles. And that's why the major portion, the thickest portion of the adrenal cortex is called the zona fasciculata. Whereas the glomerulosa was concerned with salt, the fasciculata is mostly involved with sugar, okay, glucose. It makes the glucocorticoids, of which cortisol is the principal hormone. So as the glomerulosa makes aldosterone, fasciculosa makes cortisol. There's a third layer, and it's closest to the medulla, and it's also steroid like the other 2. But these steroids have more sex characteristic properties, a variety of androgens and estrogens. They're called the gonadocorticoids. Now, if you want to know a really easy way to remember this, I wish I could tell you I invented this, but it seems like just about everybody knows it. And even one of my professors in medical school mentioned it. If you remember that the adrenals technically are on top of the kidney, and the kidney has a glomerular filtration rate, then if you go from the surface to the medulla, it's also GFR. Another saying that one of my students came up with, and I don't know if it was her own idea or if she read it somewhere, but she said the expression, the deeper you go, the sweeter it gets. So on the surface, we're dealing with salt regulating steroids. In the middle, you got something sweeter. You got sugar regulating steroids. And then the sweetest of all, some people might say, is sex. So the deepest layer, where the cells are arranged like a reticular pattern, are the gonadotropids. So GFR, salt, sugar, sex, if you don't know that already. And here's another nice normal couple of adrenal glands. Every time you do an autopsy, you see these things, you lay them out. There's usually a good amount of fat on them, but if you're careful to peel away the fat and you're at the capsule, they only weigh about 4 grams each. Now, I guess if you were here personally, or I could even ask you now, I could say, which one of these 2 adrenal glands, even before you dissect them or cut them or slice them, which one of these 2 adrenal glands looks flatter, more pancake-like? Is it the one on the left that has kind of a hill in the middle, or is it the one on the right that looks more like a flat pancake? Well, you say, well, why are you asking me that? Well, I'll tell you why. Which one do you think has a liver on top of it between the kidney? That would the one would you expect would be flatter. Now, I don't know if that's the reason, but the right adrenal gland is usually flatter than the left. Here, I'm going to show you a nice little histologic picture too. Do you see how this is not terribly flat? It has that nice big mountain or bump on top. This is probably the left adrenal gland because the right adrenal gland has to live between the kidney and the liver, so it's flatter. But the thing that you really want to notice, you can obviously see the fat around the capsule. Okay, but what you can also see is that the adrenal cortex is about 1 millimeter thick, maybe 2, okay? And it is very well demarcated from the medulla. So the cortex is yellow, the medulla is red. The medulla is red is because it's more vascular. There are veins in there called central veins that make the medulla look very, very red. And whereas you have cells in here metabolizing cholesterol to make various corticoids, sex, sugar, and salt hormones, you don't have that kind of hormone coming out of the medulla, because you know the principal hormone of the medulla is epinephrine and norepinephrine. So there we go. There's your little superficial layer under the fat. I don't think I could make it bigger. Maybe I can. Let's see. I didn't intend to. But look, do you see how the cells in the glomerulosa look kind of like more like little balls? Maybe you have to have an imagination, but they look like little glomeruli, little balls. But then the thickest layer are the ones that are straight. They look like fronds, or what they call fascicles. And finally, towards the surface, before you get to this very, very vascular medulla, the cells are arranged, kind of like a woven basket, or what they call like a reticulated pattern. There's a snake called a reticulated python, and I think I'll show you a picture of that somewhere along the line. But here's the salt up here. Here's the sugar, which is most of it. And then here's the sex. And if you want to go even deeper now into the medulla, the next thing would be, after you go from salt to sugar to sex, now you got stress, because the hormones of the medulla are involved in stress reactions, as you know. Here, I'm going to put this down to its normal size again, so it's properly labeled. Let's see, did I do that? Yeah, there you go. If you remember, the adrenal cortex is stimulated by ACTH. That's why it's called ACTH, adrenal cortex stimulating hormone, okay? So technically it should go or control or regulate or positive feedback to all of these three different layers. However, primarily and usually when you have an excess of ACTH, the primary effect is usually on the thickest layer, which is the fasciculata, which is involved with sugar metabolism or cortisol, okay? It's the most common of the three. However, technically, when you say ACTH, you cannot exclude the glomerulosa with the salt hormones or the reticularis with the virilizing or feminizing type hormones. And they're usually virilizing. There are some cases of feminizing, but most of, even though that makes both types of hormones, the effect of excessive gonadotropins is usually virilizing. Okay. So let's talk about the thickest layer and the most common syndrome and the one that has the most primary control of ACTH. And that would be an excess of hormone, generally called cortisols, from the thickest, most important, most common middle layer, the zona fasciculata. Somebody with excessive cortisol will be fat. I showed you this picture a couple days ago, but I'll show you again. They might have not only central obesity, but their face, especially around their cheeks, will have also increased fat. So they might look like the man in the moon, you know? They call that a moon facies, and that's a legitimate medical term. I don't know if it's still politically correct or not, but there might be other names for it. They generally are weak, okay? They could be hyper, they could have too much cortisol and therefore too much sugar. They can also have increased in hair or hirsutism, whether they're male or female. They're usually hypertensive. Because of their increased sugar, that might qualify them for passing all of the diabetes tests. Also, hyperglycemia is involved in osteoporosis, and they also have striae. I showed you this picture again, so just think of there's a girl whose brother's face is normal, but her face is kind of wide and a little puffy, especially towards the bottom, like the moon. That's moon facies. Buffalo hump is increased fat deposition at the nape of the neck. The obesity would mean increased fat deposition everywhere. And there you go, striae. And that's called Cushing's syndrome, generically. But remember, we're including diabetes, osteoporosis, hypertension, weakness, and hirsutism. Now, even though the term Cushing syndrome and hypercortisolism are used generally hand in hand, originally Dr. Cushing described these findings with a adenoma of the pituitary. Do you remember? The basophils secrete the ACTH, and if you had a tumor of the pituitary where there increased basophilic secretions, they would cause these symptoms too. But you can have these symptoms due to any condition in which there is increased cortisol, because cortisol is not only increased due to increased ACTH, it's also increased when you give patients too many steroids externally as well. So, what are the causes of Cushing syndrome? Technically, according to Dr. Cushing, he originally described pituitary adenoma, tumor of the pituitary, ACTH increase. There are other tumors, by the way, in which you have that can secrete ACTH ectopic from the pituitary. And here's a list of them. I could think of 3 or 4, but I actually found a couple of new ones last night. For example, obviously, the small cell carcinomas can secrete almost any type of hormone. Medullary carcinoma of the thyroid not only can secrete calcitonin classically, but also an ACTH-like substance. Islet cell tumors of the pancreas, which we're going to hear about next week, and carcinoid tumors, which often behave in a neuroendocrine type of fashion as well. They could be in the GI tract or the lung or technically anywhere. But all of these type of tumors can secrete ectopic ACTH. It might not be the exact amino acid sequence as a pituitary basophilic tumor secreting ACTH, but it's close enough to have the same physiologic of the effect to stimulate the adrenal cortex, and particularly and usually and primarily the cortisol. Would increased ACTH also cause hyperplasia of the cortex? Of course it was. But you can also have hyperplasia of the cortex independent of ACTH control. So whatever is the cause of hyperplasia doesn't matter. If that cortical tissue is increased or hyperplastic, you could have increased cortisol. Could you have a tumor of the cortex? Not just generalized hyperplasia of the cortex, but a specific tumor being functional and causing Cushing syndrome? Yes. But I could tell you, in my experience, having done many, many autopsies, it's very common to find little adenomas of the cortex of people dying from other reasons, and usually they are not functional. So just because they look yellow or microscopically like adrenal cortex, that doesn't mean they have to be secreting excessive cortisol. Could you have a carcinoma of the cortex? Well, this is one of these really rare things again. And of course, the answer has to be yes. And if you've ever seen a carcinoma of the adrenal cortex, it's usually so poorly differentiated, it's not differentiated well enough to cause adequate secretion of cortisol, okay, or other cortical hormones technically. However, the tumor can be so large that even though the cells are producing only 10% of what a normal cell would produce, but if you have a tumor that's as big as a football, then that's like 1,000 times more cells. So yeah, you could technically have a carcinoma of the cortex causing Cushing syndrome. However, we skipped the big one, and that's why I put it in these big letters. If you give the patient steroids, and generally steroids in the hospital for any reason, sometimes they're life-threatening reasons, and sometimes they have to be on them for a good amount of time. That in itself can also produce all of the symptoms of Cushing syndrome that we talked about. Now, let me ask you this. I put a little note there that said CTX thin. If you were giving patient exogenous steroids, which is the most common cause of Cushing syndrome, wouldn't that be feeding back to the pituitary and maybe the hypothalamus to tell the pituitary to shut down the ACTH? And it does. And therefore, in a person with Cushing syndrome due to exogenous steroids, the cortices are thin because of the negative feedback, normal regulation. But a person with Cushing syndrome, because of a pituitary ACTH increase, whether it's benign or malignant, or even whether it's from another type of tumor, in that case, the cortices would be hyperplastic or thick. Okay. Let's move on to another part of the adrenal cortex, called the zona glomerulosa, the part that makes aldosterone. We talked about aldosterone extensively when we were talking about renal physiology. But to make a long story short, the primary function of aldosterone is at the level of the kidney to retain sodium, which means retain water as well, right? Which means if you're retaining sodium, you're retaining water, you're also retaining blood volume. And if you're retaining blood volume because you're retaining increasing water volume, then that's a really good reason for hypertension, isn't it? So people with primary hyperaldosteronism, and we're going to show you the things that could cause it, it's also called Conn's syndrome, are usually hypertensive and they are retaining sodium. And if you remember, technically, the aldosteronism not only retains sodium but excretes potassium. And so that could cause a muscle weakness. So you want to call this a triad of Conn syndrome: muscle weakness, sodium retention, edema, and therefore hypertension. Okay. What might cause an increase in aldosterone? Well, don't forget, if you have a cortical neoplasm, there's no law saying it only has to secrete cortisol. It can also secrete aldosterone. It doesn't secrete aldosterone as much as it does cortisol, but that's a possibility. Or once again, if you have cortical hyperplasia due to any reason, whether it has something to do with the pituitary or not, that's another reason for increased aldosterone. And there's also something, of course, I've never seen, and you'll probably never see it unless you Google it, but there are also familial primary hyperaldosterone or Conn syndromes as well. What about secondary? Well, probably secondary hyperaldosteronism is one of the most common reasons for hypertension. Because if you remember the RAAS axis, whenever you have decreased renal perfusion, that kicks in the renin, that kicks in the angiotensin 1, angiotensin 2, and that ultimately triggers the aldosterone. So most of the causes for secondary hyperaldosteronism are decreased renal perfusion. And of course that would result in edema because you're retaining sodium. So you can have problems with heart, liver, or kidney. These are other reasons for edema, isn't it? So here, I think I didn't explain that properly. If you had generalized edema because of congestive heart failure or chronic liver disease where you're not making enough oncotic proteins or other kidney disease, that would be related to secondary hyperaldosteronism as well. And it occurs a lot in pregnant women as well. Whether it's a renal effect or something other than that, I really don't know. But a pregnant woman is at risk for increased aldosteronism, increased blood pressure. It might be even part of her preeclampsia type situation that we talked about a couple of weeks ago. Okay, we're down to the last layer. We've been through sugar, we've been through salt. Let's talk about sex. The hormones, the steroid hormones of the adrenal cortex from the reticularis layer can be either androgen-like hormones or estrogen. So they could either be virilizing or feminizing. However, practically speaking, most of the time, it's virilization, okay? So if a baby is born with a woman baby, a female baby, a baby girl, pink, not blue, but she has some masculinization properties. She might have a cortical neoplasm that's producing too many virilizing gonadocorticoids, or she could just have cortical hyperplasia. It's very, very closely linked to a 21 hydroxylase deficiency. In fact, these two terms are almost used interchangeably: adrenogenital syndrome and 21 hydroxylase deficiency. And this deficiency, genetic, they're born with it, they inherit it, They're probably autosomal recessive, okay, would result in a baby girl being born classically with secondary male or virilizing type properties. Now let me show you something that's interesting. When we talked about the adrenogenital syndrome, okay, or when we talked about hyperaldosteronism, whoops, I'm sorry, let's go to this one here. We said cortical neoplasm, cortical hyperplasia. Did you notice it did not say anything about the pituitary gland? So when you have an excess of ACTH, it's much, much, much more likely to produce increases of cortisol rather than aldosterone or the so-called sex steroid hormones. Okay. Now you know we're going to be talking about tumors, and these should all be pretty logical. Remember I told you that the average thickness of the bright yellow adrenal cortex was about 1 millimeter? Well, you should also remember that it should be fairly uniform as well. So if you take out an adrenal for whatever reason, you start slicing it, normally this cortex is very, very yellow. Why is that? Well, because most of those steroid precursing cells have cholesterol. Cholesterol is a fat. Fat looks yellow. If you do see them microscopically, that fat dissolves and the cells look foamy, okay? But take a look at the ruler down here. Here's 1 centimeter from here to here. The thickness of that cortex is not much more, or maybe even slightly less than 1 millimeter. So when you look at a pathology report and somebody has dissected the adrenals and they're normal, they might say something like, the adrenal cortices are uniformly 1 millimeter and well demarcated from the redder, more vascular, more hemorrhagic adrenal medulla. So the red stuff is the medulla and the yellow stuff is the cortex. Now look, the cortex is so thick here, uniformly pretty much, that you hardly even see the medulla at all. Maybe there's a central vein there or some medullary tissue, but this is adrenal cortical hyperplasia. Okay, doesn't that make sense? And look, the thickness of this from here to here looks like it's about, maybe 2 or 3 millimeters and fairly uniform. Now, let's get into something cool. Here you can see a nice yellow 1 millimeter cortex with the 3 layers. Here you see some nice red medullary tissue. You can see good demarcation between the yellow cortex and the red medulla. And look, let's drive down this yellow cortex highway, and we're driving down, it's 2 lanes, and boom! All of a sudden this yellow cortical tissue becomes massively and focally enlarged. Well, you know that has to be an adrenal cortical adenoma, right? It's no longer just hyperplasia where the cortices are thickened, but now we have an actual tumor. And I called it an adenoma, but in all honesty, you have to call it a tumor. These are actually kind of common, and even though it looks like there's more yellow tissue in here than there's the rest of the adrenal, they may not be functional. They may be dedifferentiated enough not to produce significant increase in the patient's cortisol or other steroid hormone, adrenal cortical hormones. But the one thing you know for sure is that this tumor is arising from the cortex because it's the same color and the same texture. It is not arising from the medulla. If it was arising from the medulla, and we'll talk about medullary tumors, it would be red like the medulla rather than yellow like the cortex. Now we talked about all kinds of reasons for increased adrenal cortical hormones. What about decrease? There's 3 sort of syndromes that are result or in decreased adrenal function or adrenal insufficiency. One of them is called primary acute. One of them is primary, it's mean the cause is in the adrenal gland, but it's a chronic, long-standing disease, and it's much less dangerous or much lower morbidity and mortality than the acute stuff. The acute adrenal failure is called a crisis. It's called an Addisonian crisis. The chronic form of the disease is also called Addison disease, but it could go on for many years. There's a guy who had Addison's disease for many years, and then he died of a bullet hole in the head. That was John F. Kennedy. He had Addison's disease. Or you could have adrenal insufficiency because of the inability of the anterior lobe of the pituitary to secrete ACTH. So that's secondary adrenal insufficiency. So let's talk about primary acute. Did you notice that when you are on steroids or you put your patient on steroids, you cannot just cut those steroids off and boom, like aspirin. If the pain goes away, you don't give any more aspirin. But if the patient doesn't need steroids anymore, external steroids or exogenous steroids, you have to taper them, because if you don't taper the patients that are on steroids and you withdraw it rapidly or suddenly, they could go into acute primary Addisonian crisis. Another cause for acute, chronic, life-threatening Addisonian crisis is a syndrome called the Waterhouse-Friderichsen syndrome, and it's due to the fact that certain infections, significant systemic infections, not only involving the adrenals but other parts of the body like meningococcus, staphylococcus, Haemophilus, and even shock, where there's an element of DIC, can also result in sudden acute lack of adrenal cortical hormones. Babies that are born with very difficult delivery, patients that are on anticoagulants may hemorrhage inside their adrenals, and also DIC patients, especially post-surgical DIC patients, may go into sudden adrenal shutdown as well. That's serious. The acute adrenal insufficiency is serious. We've given you some of the things it's related to. But here's one that many more people have, and they're controlled on it with maintenance steroids, perhaps even low dose, and it's called chronic. And it doesn't have the morbidity or mortality of the acute. It's also called Addison's disease. And the reasons for this is much more easy to understand. Do you remember when we talked about thyroid? We said there's an autoimmune disease of the thyroid where you have lymphoid follicles and antibodies attacking the thyroid tissue, autoantibodies. Well, the same thing can happen with the adrenal as well. So adrenal antibodies, can attack the adrenal cortex. It causes a whopping lymphoid reaction as well. And that is the reason and the cause and the histology of Addison's disease. Not Addisonian crisis, which is the acute, but chronic Addison's disease. Certain infections, fungal infections, systemic fungal infections exactly, like histoplasmosis, not a superficial, but a deep fungal infection, is also linked to primary chronic Addison's disease. And I have to tell you a personal story about this next one. And I included the word metastases. And of course, you're going to say, well, if something metastasizes to the adrenals, they might slowly lose their function. Yeah, that's true. But I can remember one of the first autopsies I've ever attended, even when I was a medical student, before I became a resident. The pathologist was dissecting the adrenal glands very, very, very carefully in a patient with lung carcinoma. And for some reason, which, I don't think anybody really knows, lung carcinomas have a predilection when they metastasize. They often metastasize early and even first to the adrenal glands. So what's the take-home point? The take-home point is that lung cancer can metastasize anywhere, but one of the places it loves to go to early for a crazy unknown reason are the adrenal glands. And finally, you could have genetic disorders that result in impaired adrenal cortical function as well. Let's see. I'll tell you what. We've already done an hour, and I told you this is not going to be very long. So here's what we'll do. We'll take our break now, and then we're going to come back and just do a few more slides. And I'm going to keep my promise that this is going to be a short webinar, so we're not going to go very, very much into the second half, maybe 5 or 10 minutes. So let's give you 3 more songs from our song box here, and we'll see you in about 10 minutes. Something went wrong. Let's see if we can get a song out of this. Maybe not. Well, I'll tell you what, folks. You can probably still hear me, and I got my little gizmo here, so I'm going to take this little micro TF chip that they call it, or micro SD, and I'm going to put it into a USB adapter, and I am going to find a USB adapter in my drawer here, and then I'm going to stick it into the USB slot. So let's see if that works. Let's find a better one. That's not too good. That's not too good. That's not too good. So here, I'll take it out of here. I'll put it in the other one. Hope it doesn't fall on the floor. And we'll give you 3 songs, hopefully very soon. Well, we're back. And I found out when I checked my Facebook messages that I'm finally out of Facebook jail. It was another 30-day stretch. I've been in Facebook jail 33 times. I don't think I say anything bad, but you know, when you get old, you generally speak your mind and you're not afraid of anything. And the people that run and control our mainstream media in the United States, and also our malignant people that control large portions of social media as well. So I've been in the slammer a lot, and actually I'm not ashamed of it, I'm proud of it. So we're back into the second half. I hope you enjoyed the three pieces of music, which for some reason didn't want to play on the micro SD slot. So I had to put them into the regular USB slot. Okay, I promised you it would be a short webinar. It's already been over an hour. We talked about all of the big things. All we have left is a few words to say about the adrenal medulla now, almost like a separate endocrine gland from the adrenal cortex. And then we're going to say just maybe 3 or 4 brief words about the pineal so-called gland. I don't know why it's called gland, and it's certainly not really too much of an endocrine gland, but you know, everybody's buying melatonin these days, and they want to know about the pineal, and they think that it's a third eye, so we'll say a couple words about that too. So we did most of our stuff here. We only got about, maybe 12 things left to talk about briefly. So let's keep my promise and go into the last few remaining PowerPoints. Neoplasms. Well, neoplasms are always the last thing that we talk about when we talk about any system, including endocrine system, and now the adrenal gland, and specifically the adrenal cortex. We went into this type of benign cortical adenoma in great detail. You know, it's a great thickening of the yellow cortex, and it's focal, so you know it's an adenoma. You know it's cortical. It's not medullary. If it was medullary, it'd be red. Okay, here's another cut section of it. And remember, these are generally called adrenal cortical adenomas. If they produce an excess, for example, in cortisol, they're not going to call it a basophilic adenoma or an acetophilic adenoma if it has to do with growth hormone or whatever. These are just cortical adenomas. They all look the same. They don't differentiate into acetophils, basophils, so forth. Here's a nice cut section. Okay, and once again, in many, a good percentage, a high percentage of autopsies, if they're done carefully, you will find a focal thickening of this yellow uniform cortical ribbon. And most of the time, the patient has never had a history of a hyperfunctioning adrenal cortex like Conn syndrome or adrenogenital syndrome or the most obvious Cushing syndrome. Here's another adrenal cortical tumor, well defined, and you see red areas mixed in, not because it's mixed in with the medulla, but because it just happens to be very hemorrhagic. It requires a lot of blood supply. And these are all classical appearances of adrenal adenomas. Now, here's the big one. And I like this picture the best because it shows you what a glomerulus is. It shows you what a frond of a palm tree or a pine tree is. And it shows you what a reticulated python is. So the top layer is the glomerulosa, which we know, the very superficial layer of the cortex. The most of the thickness of the cortex are these linear type fascicles. And then, I don't know, reticulated is really hard to describe in words, but it's like kind of a woven or crisscross pattern. And if you've ever seen a reticulated python, which you're going to see right now, that's a good reason why it's called the zona reticulata, because the cells are arranged in this kind of a reticulated pattern as well. But once again, this happens to be a very, very well-defined adrenal cortical adenoma. Here's a nice cut section. also an adenoma. And I know you're probably saying, well, why is he calling it adenoma just from cutting it with a knife? Doesn't he want to put it under the microscope and see if those cells are malignant or not? Well, it's very well defined, so technically, even if they looked malignant, the fact that this is so well encapsulated and so well defined, it would almost certainly not only be called benign, but it would be benign. There's no necrosis, there's no hemorrhage. The borders of it is sharp as a razor. Okay, and here's that third one that I showed you. And once again, you can see the cortices are yellow, but the cortices also can have a little red or pink into them. This is the tumor, and the very much redder medulla is not or does not extend into this. So you don't have any tumors of the adrenal that include both cortex and medulla. And I know what you're thinking. Is this some kind of brain? Well, actually, this is something I've never seen in my entire 150,000 years of practice. But I do know that if a tumor of the cortex was theoretically malignant, it might have a lot of areas of hemorrhage. Maybe this is a big area of hemorrhage, or maybe this could be parts of the medulla that's left over. I don't know, but this is a large tumor. Now, here's the question I posed at the bottom. Carcinoma of the adrenal cortex. And I asked you, could this be functional? And the answer is generally no. And they're usually not. First of all, they're rare to begin with. But if they do exist, they are usually not clinically functional. But think about it. Why aren't they functional? Because malignant endocrine cells are undifferentiated, and therefore they're not likely to function like normal endocrine cells. And that's the reason. Now, let's say that a malignant endocrine cell, however, is still differentiated enough to make about 5% of the hormone that the normal one would make. Well, this tumor is more than 20 times bigger than an adrenal gland, okay? So technically, I bet if you want to Google, and I haven't done it, but if you want to Google a functional adrenal cortical carcinoma, maybe you'll find a couple. And if you do, they've probably been written up in 1,000 different places. Here it is, histologically. And of course you're going to say, well, we know that's malignant. Look how big and dark and ugly and these crazy abnormal mitoses and necrotic and hemorrhagic. This has to be malignant. In fact, I could tell you, I could show this to my 100 pathology associates and they'll just say, I don't care where the hell that's from, that's malignant. Well, that's probably correct. However, I've already said this 3 times and I'm going to say it 2 more times before this webinar is over. As a general rule, you can have extreme pleomorphism in endocrine tumors, extreme atypia, extreme hyperchromasia, and they could still be benign. So they have to be diagnosed not on the basis of what the damn nuclei look like, but what their behavior is. How invasive are they, okay? And I'm going to say it again. This happens to be a carcinoma, but technically it could be benign just on the basis of the fact that endocrine tumors, benign tumors, as a rule, can have extreme atypia and pleomorphism. And I got that straight from the mouth of a couple of endocrine pathologists. And that's why I've already said it 3 times, and I'm going to say it at the end as well. Okay, let's move on to the medulla. Primary disease of the adrenal medulla is a tumor. It's called a pheochromocytoma. It's a very rare cause of hypertension. Okay, so somebody comes into your office with hypertension, probably a pheochromocytoma is probably the very last thing you'll think of, but it's possible. But you're not going to all of a sudden be doing angios or CTs of the adrenal glands just because you have hypertension. And there's even a physiologic test you could do a challenge test, which is very, very diagnostic of a adrenal medulla. And that's due to the fact that as an adrenal medulla, they pour out a lot of steroid stress hormones, particularly norepinephrine. There is a 10% rule for pheochromocytomas, which I guess would be 90% if you look at the other end of the coin. About 10% of the adrenal medulla primary tumors, or pheochromocytomas, they arise in a setting where there are other endocrine tumors. There are a couple of syndromes we're going to mention called the multiple endocrine neoplasm. There's MEN1 and there's MEN2, and some of those would have pheochromocytomas as part of multiple endocrine neoplasms. 10% are extra-adrenal. If you remember, the adrenal medulla arises separately from the cortex, and it has a certain area that it crawls through or develops into before it actually gets into the adrenal gland itself. 10% are bilateral. Only 10% are malignant, and about 10% are in kids. Now, let's go into this thing right here, because this is the most important thing. Only 10% of pheos are malignant. However, histologically, characteristically, usually they have an extreme amount of pleomorphism, so they might look malignant, but they do not behave malignant, and they're very well encapsulated, and they're not necrotic, but they could have bizarre, huge nuclei, but they're still benign. However, 10% are still malignant. Here's a pheochromocytoma, and remember when we showed you a cortical tumor, it was yellow, like the adrenal cortex? Well, look, here's the adrenal medulla. This tumor now has the same color and consistency of the adrenal medulla. So you know it's adrenal medullary tumor rather than adrenal cortical tumor because it's red or pink or not yellow. This is a typical benign pheochromocytoma. I've seen a good number of these, and every time I look at the actual cells, you think, oh my God, this must be malignant. Look at that giant cell. You know, it's 20 times bigger than the cell next to it. This has to be malignant. They're not. Extreme atypia, hyperchromasia, pleomorphism are characteristic of benign pheochromocytomas as a rule, not an exception, but a rule. There's another tumor of the adrenal medulla. Pheos aren't the only thing. Pheos, of course, are much more common than the second type of adrenal medullary tumor. This is a neuroblastoma. When we talked about the upper respiratory tract, we talked about them being in the nasal region. When we talk about pediatric tumors, they could be large solitary abdominal tumors, but this is technically arising from the adrenal medulla. It's called a neuroblastoma. Now, wherever you see a neuroblastoma, whether it's in the nose or the abdomen of a little kid or the adrenal gland of an adult, once again, this could have a significant pleomorphism too. But the diagnostic feature, which would enable you to call it a neuroblastoma before you get out all the different stains, is that they have rosettes. And a rosette, like we saw before in the upper respiratory tract, is a little cluster of pinkish tissue surrounded by clusters of rather benign looking cells. There's a rosette. Maybe that's a rosette. That looks like more like a classical rosette. That could be a rosette. So anyway, you should know that neuroblastomas could be found in different settings, whether they're in the kids or whether they're in the nasal region, or now even primary in the adrenal medulla as well. And these might be one of my two last pictures, but we've already said this a few times. this is one of the major principles of pathology, by the way. If you have an endocrine gland that produces hormones, and that's the classical definition of endocrine, isn't it? It's cells that produce compounds which travel through the bloodstream to do their action on other cells. And there's probably a lot of examples of that in the body, simply besides the few classical endocrine glands we've been talking about for the last couple of days. But functioning carcinomas of the thyroid, of the adrenal, of the pituitary, carcinomas are very, very rare. And the key principle of that is, if a cell is undifferentiated enough to be malignant and look malignant and invade like a malignant cell, it's probably not going to be differentiated enough to make the hormone that it's supposed to make. Okay? And we saw this with the pheochromocytoma as the hallmark example. We saw a benign tumor that had a bizarre nucleus. Okay? So we said that benign adenomas, like that pheo, or other things in the thyroid and the adrenal, they could have a lot of extremely bizarre, dark, ugly, lumpy nuclei, but they're usually benign. So you have to diagnose them, not just on how the nuclei look, but how they behave. For example, if you saw those inside of a blood vessel, you might think, even if it looked nice, it's probably malignant. And we've been talking about endocrine neoplasms. There are a couple of syndromes called MEN1 and MEN2. And the MEN stands for multiple endocrine neoplasia. Now, in the past, they were just called Wermer syndrome and Sippel syndrome. So now they are more properly called MEN1 and MEN2. So Wermer syndrome, or MEN1, technically is characterized by hyperplasia of the parathyroid, pancreatic islet cell tumors, and a pituitary adenoma. And usually it's a prolactinoma. So if this seems like it's hard to remember, just remember Wermer syndrome is 3 P's. Hyperparathyroid, pancreatic, endocrine or islet cell tumors, and pituitary adenoma. That's MEN1, the 3 P's, Wermer's syndrome. Now in MEN2, formerly called Sippel, we have a 2A and we have a 2B, because pathologists love to just classify things to no end, right? So in Sippel or disease, or MEN2A, is usually associated with the medullary carcinoma of the thyroid. And remember, we talked about the medullary carcinoma of the thyroid being derived from the parafollicular cells, not only producing a lot of calcitonin, but a lot of amyloid too, okay? With parathyroid hyperplasia again, and a pheochromocytoma. So not only can pheos be by themselves, but they could be part of MEN2, also known as Sippel syndrome. Now, in MEN2B is different from MEN2A because there's no parathyroid hyperplasia, there's no hyperparathyroidism, but instead they often have neuromas, if you want to remember that. But the thing I would remember is that both of them are associated with medullary carcinoma. So when you see a medullary carcinoma of the thyroid, it could very, very easily be part of MEN2A or MEN2B. And finally, even the third type, which is a familial variety, is a medullary carcinoma that runs in the family. So, you know, their closest relatives may have it too. And if you think we're done, we're almost done. I got a couple more things to show you. Pineal gland. I don't know why it's called a gland, but don't forget, a lot of the endocrine tissues we're talking about technically are not real glands, you know, like the adrenal medulla or perhaps the posterior pituitary. As far as I know, I've never seen a primary disease of the pineal gland. However, because it's part of the brain and it has glial cells in it, you can have a pinealoma, which is a tumor of those neural or glial cells. Now here's something interesting. There's two types of pinealomas. There's the pineal blastomas and there's the pineocytomas. Now just like a blast is usually a younger cell than a regular cyto, the blastomas are primarily in kids and the cytomas are primarily in adults. Now, I'm not saying this is a pineoblastoma because there's a wide variety of cells. Here are some glial cells, but you have these pineal cells, which I think you might say are modified glial cells. You know, just like we said that certain other cells, like the cells in the posterior pituitary, the pituocytes, were also modified glial cells. And you can see a blood vessel here. And you don't really see a gland at all. But the one thing that you do see in almost all adult pineal glands, and the radiologists rely on this, is that most adult pineal gland have these little calcified bodies. They call it pineal sand, okay? Or maybe you think it looks like a samoma body. But basically, amid these glial pineal tissue, you got these little calcified bodies as well. Why does the radiologist rely on this? Because as you remember, the pineal gland is exactly right in the midline sagittal plane of the brain. So if they're doing an MRI, or let's say more likely a CT scan, and they want to know if they're covering the midline, and they see these little clusters of sand on the film, then they know that that's the pineal. So the pineal is identified not by the cells, but by the calcified bodies, radiologically anyway. And I think that's all that we wanted to say. Could you say that because it secretes something called melatonin, okay, which is a result of the pineal's exposure to a certain amount of light during the day and a certain amount of lack of light during the night, that because of that, it secretes a hormone called melatonin, very, very popular. Almost everybody in the hospital gets it. I got it when I was in the hospital last year. And it basically helps you sleep. But in the case of the pineal, it's really manufactured according to the circadian rhythm cycles of day and night. And therefore, secondarily, it's involved with sleep. I think we're done. And when we come back next week in 5 days, which is the day after Valentine's Day, we'll be talking about probably the most important endocrine gland of your entire body, which is not generally known classically as an endocrine gland, but it's the islets of Langerhans within the pancreas. Because the diseases due to the endocrine pancreas far, far, far outnumber all the other diseases we talked about, because they're intimately related with one of the most common diseases and perhaps one of the biggest killers as well, called diabetes mellitus. So that's how we're going to do. And also, you know, we are not going to have a terribly short session, because we also may do on our third one possibly either a review for the USMLE or a histopathology lab microscopy review. So I'm going to make up for the fact that I'm letting you out a half hour early today. And let's play our final song. And let's hope it works this time. Well, that was a pretty sudden ending. But in terms of what Gloria Estefan just said, when she was kept saying, reach higher, one of my dreams has always been that on the basis of what I do here will help you to reach higher. So, rock on, buzzards. Whoops, let's put it in focus.